All right, let's jump right into our explainer on acute stroke management. Now, if you're a pharmacy grad studying for the PBC MCQ exam, this is for you. We are going to cut right to the chase and focus on the high yield info you absolutely have to know.
First things first, let's talk about recognition. You've all seen the FAST acronym, and yeah, it's a great public awareness tool, but for us as clinicians, it's something more. It's the first alarm bell, a signal that a neurological emergency is happening, and the clock has officially started ticking.
So what are we really dealing with here? A stroke is, at its core, a sudden focal disturbance in the central nervous system, but right away we hit a massive fork in the road. About 85% of the time, it's ischemic, caused by a clot, a blockage. The other times, it's hemorrhagic, caused by a bleed. And this one distinction, it's going to dictate every single treatment decision we make from here on out.
So here's our game plan. We'll start with diagnosis, then we'll dive deep into managing ischemic stroke, both acutely and for prevention. After that, we'll switch gears completely to hemorrhagic stroke, and we'll wrap up with some really important considerations for special populations. Okay, let's get into our first section, recognizing and diagnosing stroke. When we talk about this, two words should be in your head: speed and accuracy.
But before we get bogged down in the how, let's lock in the why. What are we trying to achieve? Well, it's four things really. 1, stop the brain damage in its tracks. 2, head off any complications before they start. 3, lower the risk of this ever happening again. And 4, the big one, get the patient as much function back as possible.
Think of this as the playbook for the emergency department. The second a patient with a suspected stroke hits the door, this complex, time-sensitive algorithm kicks into gear. It guides every single step, from labs and imaging all the way to the final treatment call. And that whole pathway starts with two things: history and physical. And let me tell you, the single most important question you can ask is, what was the time the patient was last seen well? That piece of information determines eligibility for our most powerful treatments. Then, of course, you make sure their ABCs are stable and you quantify the stroke severity using the NIHSS score. At the same time, we need tests, and we need them like yesterday. While labs are being drawn, the absolute #1 priority is imaging. We need an urgent, non-contrast CT of the head to answer one simple, critical question: is there blood? Because you can't give a clotbuster to a bleeding brain. A CT angiography, or CTA, can then follow to help us pinpoint where any big blockages might be. So, let's say the CT comes back clear, no bleed. That's our green light. That confirmation pivots us directly into our second section, reperfusion therapy. The goal now is simple: get blood flow back to that starving brain and do it fast. And this brings us to that critical fork in the road we talked about. The clock is ticking, and we basically have two powerful ways to get that blood flowing again. The choice really depends on the patient, the type of clot, and that all-important time window.
Option 1 is endovascular thrombectomy, or EVT. This is where we physically go in and pull the clot out. It is an absolute game changer, but it's not for everyone. It's for patients who have a disabling stroke caused by a large clot in a major artery and who still have a lot of salvageable brain tissue. The standard window is 6 hours, but for some select patients, we can push that all the way out to 24 hours.
Okay, path number 2 is pharmacology, using the drug alteplase to dissolve the clot. More people are eligible for this, but, and this is a big but, it comes with a long list of contraindications. And guys, this is classic exam fodder. You have got to know these exclusions cold. Things like active bleeding, recent major surgery or trauma, sky-high blood pressure, or being on a DOAC. This is a really interesting slide because it shows where we are now and where things are headed. Right now, the standard is alteplase, which is a 1-hour IV infusion. But the emerging alternative is tenecteplase, or TNK. And the huge advantage? It's given as a single IV bolus, just a quick push. Logistically, that's a massive win in a time-critical situation, even though it's not yet approved in Canada for stroke.
Now, with a powerful therapy like this comes significant risk. The one we all fear is turning an ischemic stroke into a hemorrhagic one. If your patient suddenly gets worse neurologically, you have to assume the worst. That means you stop the infusion immediately and get them to CT stat. The other big one to watch for is hemilingual angioedema. It's rare, but it's a potentially fatal swelling, and it's something we see more often in patients who are already on an ACE inhibitor.
So how do we manage those risks? With incredibly tight monitoring for the next 24 hours.
I'm talking blood pressure and neuro checks every 15 minutes for the first 2 hours. And this is crucial. You hold all other antithrombotic meds, no anticoagulants, no antiplatelets for a full 24 hours until a repeat CT scan gives us the all clear that no bleed has occurred.
All right, so we've made it through that hyperacute 24-hour window. Now our focus starts to shift. We move into supportive care on the stroke unit, and just as importantly, we start thinking about secondary prevention. How do we stop this from ever happening again?
Okay, antiplatelet timing. This is a super important, super testable point. The logic is simple. If the patient did not get thrombolysis, you start ASA 160 ml right after that first CT confirms no bleed. But if they did get alteplase, you must wait that full 24 hours and get a clean repeat CT before you start. For smaller strokes or TIAs, we'll often even use dual antiplatelet therapy for that first month to really beef up their protection. Now, what if the stroke was caused by atrial fibrillation? Well, we know we need to start an anticoagulant, but the question is, when? Too early and you risk turning the ischemic area into a bleed. There's a handy guide called the 1-3-6-12-day rule. Basically, you wait longer for bigger strokes. These days, DOACs are definitely preferred over warfarin, and you'll often see a repeat scan done right before starting just to be safe. You know, reperfusion therapy gets all the glory, but this stuff right here, excellent supportive care, is just as critical. This means things like screening for swallowing problems to prevent pneumonia, being aggressive with VTE prevention, and maintaining tight glycemic control. Both high and low blood sugar are bad for the healing brain. Okay, deep breath. We need to completely flip our thinking now. We're switching gears to hemorrhagic stroke, where our goals are the exact opposite of everything we just talked about. Here, the mission is to stop the bleeding. For a brain bleed, this algorithm shows us the very first and most important question we have to answer. Where is it? The location of the bleed is the #1 factor that determines our next steps and tells us how urgently we need to get neurosurgery involved. Okay, pharmacists, this slide is for us. This is our moment to shine. If your patient has a brain bleed while on an anticoagulant, we have to reverse it, and fast. You need to know this table inside and out. Warfarin gets PCC and vitamin K. Dabigatran has its specific reversal agent, idarucizumab. And for the factor XA inhibitors, we have andexanet alpha, though it's not always easy to get. Remember how we talked about permissive hypertension and ischemic stroke, where we let the BP ride a little high? Throw that right out the window here. With a bleed, high blood pressure can literally make the hematoma bigger. So aggressive BP lowering with IV drugs is a cornerstone of management to contain the damage. Now, for a very specific type of bleed, a subarachnoid hemorrhage from an aneurysm, there is one drug you must associate with this condition, nimodipine. This is one of those drug disease pairings you just have to memorize. We give it for 21 days, not to treat the bleed itself, but to prevent a devastating secondary complication called vasospasm. And the main side effect you need to watch for is, you guessed it, hypotension.
All right, last section, let's tackle a couple of special populations that always seem to pop up on exams and require some really nuanced management: pregnancy and breastfeeding.
It's really important to realize that stroke risk goes way up during pregnancy and in the postpartum period. And here's the kicker. Unlike in the general population, these strokes are actually more likely to be hemorrhagic than ischemic. It completely flips the usual ratio on its head. The most important takeaway here is that we do not withhold life-saving acute stroke therapies just because a patient is pregnant. A non-contrast CT is safe for the fetus. Alteplase is considered a reasonable option. EVT should absolutely be offered if it's indicated. And when it comes to anticoagulation, low molecular weight heparin is our go-to since warfarin is a known teratogen. Now, for a lactating patient, our medication choices really hinge on whether the drug gets into the breast milk. Alteplase is probably fine, since it's likely just destroyed in the baby's stomach. Low-dose ASA, LMWH, and even warfarin are all considered compatible. The big exception? The DOACs. Their safety just hasn't been established, so we generally steer clear. So, after all of that, after looking at all these complex algorithms, time windows, and all these different drugs, what is the single most valuable prescription we can possibly give to a stroke patient?
It always comes down to time. Every single minute we delay treatment, millions of neurons die. Time is brain. And understanding these pathways is what allows you to act quickly, decisively, and save it. Thanks so much for joining this explainer.